So good morning or good afternoon to everyone on today's webinar. We're going to go ahead and get started on our third part of our three-part series on high impact HIV prevention. Today's webinar focuses on high impact HIV testing, and we're so glad that you've been able to join us. Today's webinar is hosted by Capacity for Health. We are a capacity building assistance program of the Asian Pacific Islander American Health Forum. We have offices in both San Francisco and DC, and today's webinar is being hosted out of our San Francisco office. So we are a capacity building assistance program, and that means that we provide support to organizations that do HIV prevention. We're actually funded directly by the CDC, so all of our support services are free to organizations. And we do really wraparound support. So we do trainings, we do webinars, we develop materials, and we primarily work one-on-one with organizations to help them support effective HIV prevention activities. So we can provide support around almost any topic that helps an organization to improve their prevention programming. We do a lot of work around organizational development topics.
Sonia, I'm sorry if you can hear us. We cannot hear you right now. Shelley, would you like to move forward,
or if you're interested in requesting one-on-one support.
Never mind.
So as you can see already, we're having a little bit of a technical difficulty with GoToWebinar, our server today. We're having quite a bit of a slide delay. So we're going to do our best to try to keep our narration aligned with what you see in front of you, but please bear with us and have some patience if our audio portion is not perfectly synced with what you're seeing on your screen. So before we get into our content, just a few housekeeping tips. Everybody on today's webinar has been automatically muted. We will have an opportunity for you to ask questions in a variety of ways, including asking questions live at certain points. You can do that by clicking on your raise the hand icon. However, if you're listening to audio through a telephone, you have to enter your audio PIN, otherwise we won't be able to unmute you to ask questions. We'll also encourage you to ask questions anytime during the webinar, but we'll have a specific couple of places where we pause for questions. And you can chat those in or type them in using the questions feature, which is in the lower right-hand corner of your webinar control panel. Also, if anyone's having any technical difficulty or any questions throughout the webinar, please go ahead and chat those in. We do have a very large number of people on today's webinar. We will do our best to get to all of your questions. It's possible we won't be able to address them all during the time period of the webinar, in which case we'll stay on the line afterwards if there are questions that still need to be addressed. And we'll make sure that you have information on how to contact us after the webinar if we are not able to get to your question. Also, if anyone's watching the webinar with multiple people around one computer, please use that questions window to chat in your contact information. We will do some follow-up after the webinar, including sending out links for the slide set, the recording of today's webinar, and some other resources that accompany it. As I just hinted at, today's webinar is being recorded, and the recorded version of this, along with the slides, along with a number of other resources, will be available on our website at the end of the webinar. So we're very lucky to be joined today by a fabulous guest presenter. Her name is Shelley Facente. She's been doing HIV prevention work for a very long time, and we have had the opportunity to work together on a number of projects. She has a lot of experience doing HIV testing and actually oversaw the rollout of rapid testing for the city of San Francisco a number of years ago. And we've had the opportunity to work with her over the last 4 months to develop a series of materials on high-impact HIV prevention. So high-impact HIV testing is obviously just one part of that series. We will talk a little bit at the end of this webinar about the other components of high-impact HIV prevention and where to get more resources on those as well. The focus of today's webinar is really, as we keep saying, on high-impact HIV testing. We know there's a lot of people on the call, a wide variety of participants on today's webinar, so we will cover some basics of CTR and rapid testing, but primarily we're going to be trying to focus on best practices and some of the evidence base around the proven effective HIV testing interventions, as well as a little bit of a teaser, a little bit of a spoiler about what's to come, and some new HIV testing algorithms which are currently being formalized and disseminated. So we're going to cover a lot of material. We are going to move fairly quickly, particularly very quickly through the sort of basics and overview sections around CTR and rapid testing. Don't worry about capturing all of this as we go. The slides and the recording will be available, as well as further individualized support if you would like it. So we hope that by the end of the webinar, folks have a very clear picture of sort of best practices and the evidence base around HIV testing, CTR, and rapid testing. We're going to talk a bit about new testing technologies and algorithms, but mostly we really hope that you end today's presentation knowing how to get further information, further resources that are available to you online, and how to access further support as you try to develop and refine your HIV testing services. So we're going to cover a number of things. As I mentioned, we're going to start with a quick review, sort of basic information about HIV testing, CTR, and rapid testing. We'll talk about best practices, some of the proven effective interventions that we are currently seeing disseminated by the CDC. We'll talk a bit about the up-and-coming new HIV testing algorithm, and we'll close out with some further resources. So before we do that, we always like to get a real quick sense of who's on the call. You're going to see a quick poll launch on your screen. If you can just go ahead and fill that out and let us know if you are currently doing HIV testing, what you're doing in your organization, whether that's conventional testing, rapid testing, both. Maybe you're not sure, maybe your organization's not actually doing HIV testing. Obviously, we welcome everybody on today's webinar. We're going to try to cover both the basics and more advanced topics, but it's helpful to us to get a sense of who is on the webinar so that we can best tailor the information we're sharing with you. So I'm going to give you just 3 more seconds to poll in your answers, and we'll go ahead and close that out and see who's on the call. We recognize we don't have a ton of time, and we do have a ton of material we want to share with you, so we are going to be moving quickly. So it looks like many people are already providing both rapid and conventional HIV testing, and a small portion of you aren't doing testing yet. So that's great. We'll cover the basics of testing, of CTR and rapid testing programs, and then we'll move on and hopefully cover some of the more intermediate and advanced topics for those of you who are already quite experienced. We'll have some opportunities for you to share your experiences and your best practices as well. So let's go ahead and get started in the content of today's webinar. I'm going to turn it over to Shelley, who's going to walk us through the next set of slides.
Great, thanks, Sonia. And there we go. Hopefully this is starting to come up for you. So it's great to be here today to talk about HIV testing. And as we've talked about, you all have a variety of levels of experience with HIV testing. So we'll try to balance that out and cover some basics quickly for those of you who don't already have it, since there were a good amount of you who actually aren't doing any HIV testing yet in your agency. So we'll do a little review of the basics of testing programs in a moment, but first we want to put this in context of what we actually mean when we say high-impact HIV testing. We've been using that, but it's important to talk about what it means. So this day and age, we have a wealth of HIV testing options available to us, and as you know from your own experiences, pretty much everyone in the U.S. understands that knowledge of one's HIV status is a powerful, important thing, and strategies to make HIV testing widely accessible to all of those at risk and then quickly and effectively help those who test positive to link to high-quality care can really have a significant impact on the overall HIV epidemic. So interventions that do this are really high-impact HIV testing interventions. And the name high-impact HIV testing comes from the Centers for Disease Control and Prevention's new approach to HIV prevention called high-impact HIV prevention. So most of you probably already have heard about this. Briefly, it's designed to maximize the impact of prevention efforts for all Americans at risk for HIV infection, and it builds on the priorities of the National HIV/AIDS Strategy, which was released by the White House Office of National AIDS Policy on July 2010. The National HIV/AIDS Strategy lays out a lot of important priorities for HIV and AIDS in the United States, and when it comes to HIV prevention, there are 3 main priorities: to intensify HIV prevention in the communities where HIV is most heavily concentrated, to expand targeted use of effective combinations of evidence-based prevention approaches, and to educate all Americans about the threat of HIV and how to prevent it. And so given those priorities, CDC has responded by reframing their own priorities for HIV prevention and calling that high-impact HIV prevention. And obviously, HIV testing is a really important part of that. So CDC has a website that they've specifically designed to support high-impact HIV prevention. And this website is effectiveinterventions.org. So what you see here, hopefully by now on your screen, is a picture of the homepage. There's a lot of great resources on this website, and it includes resources, news updates, trainings, but the biggest feature of the website is an in-depth description and set of resources for each of what CDC considers to be proven effective interventions for the United States. And those are on the left side of what you see on your screen. So on the actual website, when you click on biomedical interventions, public health strategies, those words, it comes up with a lot more information about different strategies in those categories. So under high impact HIV prevention, priority is given to interventions that meet a variety of criteria for being considered high impact. So those are interventions that are cost effective, that can be implemented on a large scale, they reach many people, and they can be effectively combined with other interventions to really have the maximum impact. And why we're talking about this is that HIV testing really meets all of these criteria. It's one of the reasons it's such an important cornerstone intervention these days. It's also a critical intervention to help people learn their HIV status so that they can take action to prevent further spread of HIV. So, you know, these things are why you hear so much now about HIV testing, and a lot of people feel like the focus is going so much to HIV testing, and that's really why. You're maximizing the health and life of people with HIV because they learn their status and can seek care, and you're also really able to have high impact in preventing the spread of HIV to anyone else. So high-impact HIV testing programs can include HIV counseling, testing, and referral, or CTR, which we'll talk about, rapid HIV testing, which a lot of you are already doing, and then there are other proven effective HIV testing interventions, including opt-out testing in medical settings, personalized cognitive counseling, or PCC, and RESPECT, and we'll talk about all of those today if you haven't already heard about them. So let's start with HIV CTR. CTR is a collection of activities that's designed to encourage and support risk reduction, which is the C for counseling, increase a client's knowledge of their HIV status, the T for testing, and then secure needed referrals for appropriate services, including medical, social, prevention, partner services. All of those fall under the umbrella of R for referral. So it's important when we think and talk about HIV testing to remember that the test itself is usually just one part of a CTR program, which is a little more comprehensive picture of a testing strategy. As a really quick review for those of you less familiar with CTR, we'll talk briefly about the basics of it. So although HIV testing is available in a wide variety of settings, including medical settings and other places, CTR is most frequently offered in non-medical settings, including community-based organizations and venues where members of priority populations are likely to be spending time. Providing numerous options for HIV testing facilitates access to testing and increases the chance that people at high risk for HIV infection will seek a test and learn their HIV status. So that's the idea behind it. No matter where CTR is provided, a core part of it is that it's always voluntary and that the client must provide informed consent every time, which means they fully understand the HIV testing processes, the risks, and the benefits for the type of testing offered at that specific site. So speaking of the type of testing, there's a few key terms that we want to review so that we can be sure that everyone is on the same page. You've probably heard all of these, but you may not know exactly what they all mean. So when we talk about various CTR models, there's really no one right model, and it really depends on the needs and context of an organization or a population. So keep that in mind as we move through the next slides and talk about these key terms. So the first one is anonymous testing. A person can be tested for HIV without providing his or her name, and this is called anonymous testing. If the client does provide his or her name because they just say it, it's not recorded as any part of the HIV test in this case. So in states where HIV-positive test results are required to be reported to the state health department by name, which is increasingly true in almost every state now, anonymous tests are exempt from these reporting requirements. So one of the pros for this type of testing is that for people who are really worried about their name being associated with an HIV test, they may be more likely to test if it's anonymous and they don't have to feel that their name will be associated with it or be reported. The con to it is that it is more difficult to follow up because you don't have that person's name or contact information. So if the testing site wants to provide further support, further information, linkage to care, support, all those kinds of things are really more difficult to provide with anonymous testing. It's not impossible, and some sites have been really creative about how to do it without the name, but it's definitely more challenging. So the second type of testing is confidential testing. So this one's pretty obvious after you've heard the anonymous explanation. During confidential HIV testing, the client provides his or her name, and they may also provide contact information. Ideally, they would. So because a name is provided in this case, the site can keep a client file and provide more continuous care and support, including needed follow-up. So all of that is easier. In states where HIV positive test results are required to be reported by name, though, the client must be told about this regulation and provide informed consent before the test is conducted. And sometimes that might mean that when when a client is informed, they may choose not to test. So it can be a barrier for some people. Okay, and we'll talk a little bit more in the future about rapid testing, but very briefly, rapid testing uses test technology of disposable HIV test kits that don't require a full laboratory to be accurately run. So they're often known as what's called point of care, which means they can be run for a client right at the place they seek care. So in this case, they're coming in for an HIV test, they're seeking care in that way, and you can run the test right there and provide them a result right there and not have to send it elsewhere. So rapid tests are generally conducted at the test site during the time that the counseling of CTR is happening, if it's a CTR program. And the various tests currently approved in the U.S. for rapid HIV testing take right now between 10 and 20 minutes. This picture on your screen is one of the Unigold tests, but there's a number of different tests on the market, and new ones can come to market at any time. This is a really rapidly changing field. A con of this is that positive results are considered preliminary, so receiving final results usually requires a second visit to the test site. I mean, essentially, they have to be confirmed by another different test, and so that's a little more complication in dealing with rapid tests. As opposed to rapid testing, there's conventional testing, which refers to HIV testing where a blood or oral fluid specimen is collected by the test site and it's processed separately, not during the HIV test interaction. Often specimens are sent to off-site laboratories, although not always, and results may take anywhere from a few days to 2 weeks to get the results. So in this case, in order for clients to receive their results, a second interaction from the HIV test site is always required. With conventional testing, HIV positive test results are automatically confirmed in the lab. So while they're also using another test to confirm the results, it's happening behind the scenes and one final result is coming out. You don't get a preliminary result that you give to someone and then a confirmed result. So speaking of confirmatory testing is still required in the United States for all HIV screening tests, as I was just saying. And this means that before a person can be officially diagnosed with HIV, a second test has to be done. For conventional testing right now, this is usually a Western blot or an immunofluorescence assay, or IFA, you may have heard it. And in test sites using rapid testing, sometimes the second test can be a second type of rapid test, or it can be a Western blot or IFA. And as we'll talk about later, this kind of thing is starting to really change in the country, so this is the information that's accurate for right now, for sure. And the requirements around what tests can be used and all of that right now, because things are in flux, it can actually vary state by state and probably will become more standardized as time goes on. Okay, so that was a pretty quick review of those basic terms. Now that we know everyone's on the same page, 4 of the 5 terms that I just went over are actually different models for HIV testing, so those 4 that you see in blue. And as we said at the beginning of this section, there's really no one right model. Many organizations actually offer a combination of these different models. As you saw from the poll, a lot of people were offering rapid and conventional, and a lot of sites offer anonymous and confidential testing. And in a few minutes, we'll also talk about other proven effective models like PCC and RESPECT and opt-out routine HIV testing, as we mentioned earlier. So for those of you not already familiar with rapid HIV testing, I did just go over it, but we're going to take one more minute to just, this is something that people who don't already know about it are really interested in, so we wanted to take one more minute to just talk about rapid testing. So as I said before, rapid testing involves the use of disposable HIV antibody tests that work within a very short period of time, usually 10 to 20 minutes. And on your screen you see pictures of 4 of the different tests that are really commonly in use in test sites right now. And many versions of rapid tests can be run in basically almost any setting with good lighting and a stable place to set the test, which means that this type of testing can be done in community organizations and provide near immediate results to clients, which is one of the reasons it's so popular and so many people are trying to roll out rapid testing. It gives a lot of flexibility. Rapid testing is really an important advancement for HIV testing interventions because while higher risk people are more likely to test for HIV in non-clinical community-based test sites where they already have a relationship, the data really show that many people in these non-clinical settings don't return for their test results. And if they're not returning for the results of conventional testing, then the testing intervention is really not very effective. So rapid testing allows people to receive the results on the same day they go for testing, which makes the rate of results disclosure nearly 100%, which is obviously a really big deal. So that's another reason that you hear so much now about rapid testing. Okay, so now that we've gone over the basics, there's a number of best practices for any CTR program or HIV testing program overall, really, whether conventional or rapid. So now we'll take some time to review those. And we want you to be thinking for your own sites, for those of you who are already doing testing, what are some of the best practices that you have found that we're not covering today, because at the end of this section we'll ask you to chat some of those in. So be thinking about that, because we know you have some really valuable experience and we'd like to hear that. Okay, so the first thing we would say is that it's really essential to talk to your local health department when you are not already the health department. Before you implement any HIV testing program, you really need to make sure that you're adhering to all the local, state, and federal requirements for HIV testing. And especially if you offer rapid testing where your site is functioning as a laboratory and you're providing results directly to clients, it's really essential to know those local regulations. And your health department has expertise around that. They can really help you determine what support is available in your area. They can put you in touch with other organizations that are already successfully doing CTR. And they may even have tools specific to your jurisdiction that can help you plan and implement a high-quality program. A lot of health departments can be an excellent resource to help you set it up so that you're not reinventing the wheel, because there are so many successful CTR programs around the country that you can learn from. So along those lines, another helpful suggestion is to really network with other organizations already doing CTR. So whether you already know them or whether your health department can put you in touch with them, there are organizations in the U.S. that have been doing CTR and rapid HIV testing specifically since as early as 2003. So that's a long time with a lot of experience. So whether you're the first site doing this type of testing in your area or not, there are organizations with vast experience who can really support you, offer advice, and once you contact them, you can ask to observe their services and learn from them that way. Or if you're not able to actually be there, you can borrow, a lot of places will let you borrow some of their written documents that you can adapt and make sure that you're maximizing your opportunity to get things set up with as little pain as possible for you, because sometimes it can be difficult to set up a rapid testing program specifically. So once you've done the preliminary background, next you need to start identifying your staffing needs and actually training staff. So the amount of staff you need for your CTR program will really depend on your clinic flow, the number of clients you expect to see, and more variables like that. At a minimum, you need test counselors and people to provide the results. And if you're offering rapid testing, you also need test technicians or people to run the tests. So some sites, these are the same people. The counselor basically walks to another room and runs the test, and then walks back and does counseling and goes and gets the result, and then comes back and provides the result. And in some places, that's a different person who's responsible for running the test versus talking to the client. And you may also wish to have additional staff to aid clinic flow or do other things. So it's often really helpful to role play a testing shift at your site and determine how many staff you need to complete all the necessary tasks and still remain client focused, which can sometimes be challenging. So sometimes when you actually walk through it and role play it a little bit, you realize that there's some kind of need you didn't think you had when you were planning it out on paper. And once the staff have all been identified, you need to make sure that they're trained in counseling and or the rapid test or tests that you'll be using. And each state has different training requirements. So your local health department can, or your state health department, if applicable, that can help you understand your training needs and what opportunities are available for training your staff so that you're sure that everyone has whatever training they need. Now, besides training staff, if you're offering rapid testing, in most cases you'll also need to obtain a CLIA certificate of waiver. So those of you who don't already have one, you may have heard of this infamous CLIA certificate. This process can be really lengthy to get a CLIA certificate, so it's important to submit your application as early as possible in your planning process if you're planning to start doing rapid testing. For those of you who don't already know, CLIA stands for the Clinical Laboratory Improvement Amendments of 1988. That's why we call it CLIA. And those established quality standards for laboratory testing to ensure that patients receive accurate, reliable, and timely results. So it's important. And almost all the rapid tests used by community organizations, the 4 that I showed the pictures of before, those are all considered CLIA waived. So what that means is CLIA waived tests have to use unprocessed specimens, which means it's just whole blood or oral fluid. You don't have to do anything to the specimen. They're very easy to use, and they have very little risk of an incorrectly interpreted result. They're as close to foolproof as you can get, basically. And there's many types of certifications that laboratories can receive under CLIA. You can have all sorts of complexity of the tests you can do, but in order to run CLIA waived tests, you have to get a CLIA certificate of waiver if you don't already have one, which basically just means that you're working as a laboratory that's just able to run CLIA waived tests. The alternative to that is to establish an agreement to work under the CLIA certificate of an existing laboratory. So short of getting it yourself, if there's an existing laboratory that already has a CLIA certificate and they're willing to add you as a site and oversee the lab services and take responsibility for those, then that's another way that you can get certification to run the tests. But that's really something that you'd have to work out on a case-by-case basis. So that's the very brief background on CLIA. It's also important for you to look at options for funding the test kits. So rapid testing test kits especially can be pretty expensive, and that's been a challenge for a lot of people who wanted to start a rapid testing program. So you need to start by, really you should start by talking to your local health department to see if there's any options to obtain free test kits from them or from your state health department, especially if you are the local health department. And if free kits are not available, which is often the case, then another option is to talk to your manufacturer's sales representative for your area to see what pricing plans they have for you and see what kind of deals you can work out. And a lot of smaller agencies sometimes share orders to obtain bulk discounts. So a bunch of small agencies in an area can all coordinate in some way and place an order together, and then the manufacturer is willing to give it to them at a smaller price because they're only dealing with one big order at once. So those are some ideas for dealing with funding. Once you've started building the foundation for your program, from all these other things we were talking about, it's very important that you have a comprehensive set of written policies and procedures before you begin offering CTR. And this is often something that's kind of glossed over or done in a very, sort of started late. And that's really challenging. It's fine as long as everything's going smoothly, but when things start, when anything happens that's out of the ordinary, it's really important to have something written down that says this is how we deal with this, and then you know, all the staff know what to do and how to handle every situation. So policies and procedures should address everything from testing inventory to universal precautions to clinic flow. And at the end of this webinar, we'll give you some links to actual policies and procedures to look at as examples, because there's no need to reinvent the wheel on this one. And finally, as part of your written policies and procedures, you really need to have a solid plan for ensuring quality assurance for your CTR program. And sometimes this is called CQI, Continuous Quality Improvement. So if you're offering rapid testing, specifically, you'll also need to ensure that your tests are working correctly, your technicians are using them properly, you're providing accurate results. So there's a whole other subset of things where you need to assure quality. And as we've said before, with rapid HIV testing, people with little to no laboratory training are suddenly responsible for providing a real HIV result to their clients or patients. So it's really imperative that an agency providing rapid HIV testing in a non-clinical setting has a robust quality assurance program so that any issues that arise with accuracy, reliability of the test results, those kinds of things will be immediately caught and addressed, because this isn't sort of a natural thing for a lot of the people who are running the tests. Included in a comprehensive quality assurance plan is a training program for all new and existing employees about safety and effectiveness in counseling and testing, actually laying out what that training involves and how it gets implemented for existing employees and also for when new ones start. Doing how you keep track of written records of inventory of test kits, as well as temperature of storage areas where tests and control kits are kept for rapid testing when this is applicable. Obviously this doesn't, well, inventory still applies for conventional testing, but temperature is more critical for rapid testing. Also for rapid testing, when the test technician is they're providing the results that they read directly to the client that day. So it's really important to have documentation that each of the tests is run correctly. So that includes written records of the tests, the time it was performed, the time and temperature when the result was read, all these things that later you can go back and say, oh great, that test was done correctly. We know that that person's result was accurate to the best of the test ability. So, similar to, well, related to this idea of the test working correctly, for rapid testing, the quality assurance plan should also describe in detail the use of manufacturer-provided external control kits, which need to be used on a regular basis to ensure test kit accuracy. So that basically means control kits are little vials that have blood that, or have a specimen that is known to be positive and HIV negative, so that you run the test kits on those and hopefully get a positive result for the positive control and a negative result for the negative control, and then you know that kit is functioning properly. And so if you do that on one kit from a box, you know, you test kits from that box on the controls, then you feel confident that the rest of the kits in that box should be working correctly. Testing. Regular review of counselor performance is important. Enrolling, shadowing sessions, doing in-services, those kinds of things should all be specified in the quality assurance plan. And when it comes to rapid testing, again, regular review of the test technician, or for conventional testing, if the counselor is collecting specimen to send away somewhere, how specimen is collected and how the tests are run is important to be checking in and making sure it's being done correctly, including doing some sort of competency assessment testing, or sometimes it's called proficiency testing, at least annually for each person, just to make sure their skills are up, they know what they're doing it correctly. And finally, it's also important to require regular review of selected client records to ensure that informed consent is being obtained appropriately, things are being documented, clients are understanding what's going on, and you can show that in records. That's really important. So I'll really sum up this section by just saying that the most important thing of all, if you're offering HIV testing, is to plan ahead. Think through how things will work, check with others to be sure you're covering all your bases, and write down your plans before you begin. And if you're already offering testing, this also really applies to if you're changing your program in some way. If you're offering conventional testing and you want to start offering rapid, or if you're offering rapid with a certain set of tests and you want to change to another set of tests, especially when we talk about these algorithms coming up, it's important when you make any kind of fundamental change to really plan it out, think it through, write up a change in your protocols, do a walkthrough, make sure that everybody's on board before you launch it, because we're talking about serious business here, as you all know, and we want to make sure that the first time a new service is offered to that first client, that they get absolutely accurate, high quality services every time. So that's why it's really important. Okay, so that was a lot of information that I just kind of spewed out there. So before I continue with the next section, we want to do take a break to chat some information in. So as I said earlier, we'd love to hear from those of you who are already doing testing. What are some other best practices that have helped you be successful with your HIV testing programs, especially if I didn't mention them? We'd really like to hear from you. So use your question feature to answer and start chatting some info in. But also, this is a great time to let you actually use your question feature to ask questions. So if there are things based on what I've said so far that raise a question for you, use that question feature, chat in the question, and then we'll take a quick break here. If there are any questions coming in, I think Sonia will come on and address those, and then we'll move to the next section of the webinar.
So we don't seem to have any questions waiting at the moment. We'll give people a couple of seconds to chat in either their questions or their comments. So we're definitely seeing some responses to other people's best practices. Shelley, why don't we go ahead and start on the next section, and we will take a pause to answer any questions that come in between the next two sections, because it doesn't look like we have any actual questions waiting yet.
Okay, that sounds great. Okay, so in addition to best practices, there are some proven effective HIV testing interventions that you may wish to consider, as we alluded to earlier, especially as you consider how to make your HIV testing program as high impact as possible. So we want to take some time now to discuss those. The first proven effective HIV testing intervention that CDC describes in the HIV testing section of their new High Impact HIV Prevention approach is opt-out HIV testing as part of routine medical care. So while this may not be something that you actually implement if you're not a healthcare setting, it's really important that we all know about it and we can advocate for it within our own communities, which is why we're talking about it here. So in 2006, the CDC released revised recommendations for HIV testing in healthcare settings. And these revised recommendations aim to make HIV testing a routine part of medical care, essentially allowing people to opt out if they don't want to test rather than having to opt in by asking for an HIV test. So it's considered regular standard of medical care in that setting. HIV tests are included basically for everybody, and people are told that that's part of the list of things, and then they have to say, actually, I don't want that if they don't want it. So counseling is not required with this type of testing, but linkage to HIV-specific medical care for patients who test HIV positive is a really important part of the HIV testing in medical settings recommendations. And integration with available STD testing and treatment in healthcare settings is also highly recommended. So this is something you've all probably heard about already, and it's sometimes hard for healthcare settings to get going with it, but for those who have been able to start these programs, it's usually found to be pretty effective at finding people who might not otherwise find out that they had HIV. So in addition to that, there are two other specific effective interventions that CDC is really emphasizing for high-impact HIV testing. And these are both considered effective models for HIV risk reduction counseling, so basically for the C part of CTR. Effective HIV risk reduction counseling is still an important part of HIV testing interventions, especially for high-risk individuals. And these two interventions are PCC, Personalized Cognitive Counseling, and RESPECT. So we're going to go through those a little bit now. Personalized Cognitive Counseling, or I'll stop saying that now, it's just PCC, is an intervention geared toward reducing incidence of unprotected anal sex among HIV-negative men who have sex with men, MSM, and who repeatedly test for HIV. So specifically, it's a 30 to 50-minute counseling session. It focuses on a specific incident of unprotected anal sex, and it's delivered by someone trained in PCC, and it's to be used, as I said, it's a narrow focus, so it's to be used with an HIV-negative MSM who had unprotected anal sex since his last HIV test with a male who was not his primary partner and whose HIV status was positive or unknown. So it's really been found to be effective with that group, but it's narrowly meant for that group. PCC involves a 5-step process. So in this case, the counselor assists the client to first recall a specific memorable incident where they had unprotected anal sex, then complete a PCC questionnaire, which contains a list of self-justifications used to rationalize risky behavior, and then discuss the specific incident of unprotected sex and the client's thoughts and feelings related to that specific incident. Then, related to the questionnaire, identify the self-justifications that they used during that incident of unprotected sex, and then discuss strategies to prevent similar incidents in the future. That's the idea behind it. So there were 2 research studies that tested the intervention that eventually became PCC, as I just talked about. And in both of these studies, at 6 and 12 months after the counseling, PCC participants had significantly fewer episodes of unprotected anal sex than their MSM counterparts in the comparison group. In the first study, the average number of unsafe episodes had dropped to almost half by 6 months after counseling. And this reduction was still true a year after counseling, so that's pretty impressive. And in the second study, which obviously was looking at something different, PCC participants reported being more satisfied with the counseling services they received in the intervention compared to the satisfaction of those who received a standard counseling session. It felt more relevant to them. They felt like it had more impact on them than a standard CTR counseling session. So that's one of the reasons that for people who are serving members of the specific population PCC is meant for, this is an intervention that we know is really high impact. The other proven effective intervention for HIV risk reduction counseling is RESPECT. And RESPECT is a client-focused, interactive HIV risk reduction counseling model. It's been around longer than PCC, so you may have heard of it for sure. And RESPECT takes place over 2 sessions, although organizations also use RESPECT with rapid testing, and they consider the first session kind of before the test result and the second session after giving the test result. So it's kind of 2 sessions lumped into one. RESPECT follows a very structured protocol for counseling, and it's similar to PCC. It's delivered by a trained RESPECT counselor. RESPECT works, it supports risk reduction by increasing the client's perception of his or her own personal risks and encouraging them to utilize incremental strategies to successfully reduce the risk. That incremental piece is really important. So the intervention is based on the theory of reasoned action and on social cognitive theory. And the counselor uses or creates, if it doesn't present itself, a teachable moment during the counseling session. And they use that moment to help a client recognize and register concern about their HIV risk, and then use that to motivate them to change their behavior and reduce their risk moving forward. And the counselor works with a client to develop a concrete incremental risk reduction plan. And as I said before, there's a structured protocol that really guides the counselor for each of these sessions and helps them use these incremental strategies and use or create a teachable moment when it appears. So clients who received the RESPECT counseling intervention in the initial studies reported significant reduction of risk behaviors, and they were diagnosed with fewer new STDs than those in the comparison group. And in the comparison group, they only received brief educational messages. So the change in reduction of risk behavior and STD diagnoses were really significant. And these changes lasted for at least 12 months for many people, which again is a pretty impressive, long-lasting effect of the counseling intervention. So that's the review of those 2 interventions. And what we'd like to do is another chatted-in time to hear from you and also hear any questions you have. You can ask now. And what we'd like you to do is, for those of you who haven't yet tried using PCC or RESPECT, we want you to say what challenges you anticipate experiencing if you move to a PCC or RESPECT model of CTR. And for those of you who have already used at least one of those interventions, we'd like to hear what challenges you experienced when you moved to that model. And hopefully we'll be able to take a couple minutes here to go through some of the things that you're saying and make sure we address any of those challenges as best we can before we start talking about new testing algorithms.
So while we pause to let people chat in response to this new question, I just want to comment a little bit on a few themes that came up in people's responses to what their best practices for implementing testing programs were. There were sort of 2 themes that I saw a lot of comments around. One was around how to reach specific populations, so a little bit of the sort of recruitment conversation. And folks shared that in their organization, some of the most important strategies they'd used were things like mobile testing, having multiple times and days and locations, evenings and weekends and events. One of the other themes that people were conversating about was about the importance of linkage to care. And for anyone who missed the part 2 of this High Impact HIV Prevention series, we focus specifically on linkage to care and some effective models, effective interventions for linkage to care. So the recording of that webinar as well as an online training module are available on our website. We'll give you the link for that at the end of today's webinar. And then we had a couple of questions. We have one question about specific rapid testing configuration. Someone commented that their health department was suggesting that they use Clearview and then do OraQuick as the confirmatory test. And I actually want to just say that we are going to talk about the new recommendations around rapid testing algorithms in just a minute. So hold that question, and if we don't answer it in the next section, then we'll come back to it. We also had a question about testing in emergency rooms. And that is definitely something that we've seen a lot of in recent years. We saw it in the Bay Area, actually, in the last 5 or 6 years. We've seen a lot of ERs take up testing programs. And one of the things that Shelley mentioned in high impact HIV prevention and high impact testing is this emphasis on opt-out testing in medical care settings. And ERs are actually one of the places that are considered a medical care setting, and they're really encouraging opt-out testing in ERs as with other medical care settings. So that is definitely considered a best practice and a piece of the high impact HIV testing model that we're seeing being promoted right now. So I'm not seeing any other questions at the moment. Maybe we'll go ahead and move into the next module and then come back to any other questions that come in.
Great. Okay, so for the last major part of this webinar, we'll be talking about new testing algorithms. And so there's a lot of information about that and that I'll be sharing. And as Sonia hinted to earlier, some of this is sort of a teaser for what is coming. It's not necessarily happened quite yet, and we'll talk about that a little bit. So the idea behind testing algorithms is that by using the advanced technology we have available to us today, we can select an appropriate combination of tests in order to provide a highly accurate result to a client as quickly as possible in order to link them more efficiently to care. So what combinations of tests to use and in what order also impacts the language of preliminary positive, confirmatory testing, all that language we've been talking about in terms of rapid testing, and language that really may be shifting soon as we shift to some of these algorithms and grow more comfortable with what this is like. So just briefly, the Association of Public Health Laboratories and Centers for Disease Control and Prevention have been working together for years to develop these new testing algorithms. Literally years and years this has been in the works. And recently the Clinical and Laboratory Standards Institute, or CLSI, released the new guidelines for HIV testing algorithms, which was a really big step. But the CDC hasn't done so yet. They're due to release their related guidelines in the next couple of months, and that will be when you really start to see a sea change in how these algorithms are implemented. So depending on exactly what the CDC recommends, we're really likely to see big changes in the way that we currently do HIV testing. And everything in this section coming up is based on the new CLSI recommendations, but has not been finalized in any new CDC or state level policies. So some states are using pieces of it, or local areas are using pieces of it, but officially this isn't out there yet. And like I've said, these are likely to take some time, but we think it's important in this webinar to give you a sneak preview of what's sure to be up and coming. So the current HIV testing algorithm that most people use has a number of challenges, and we want to talk about that first. The first challenge is that most HIV testing sites that are using rapid testing, especially community-based test sites, can only give a preliminary result to people. And when a client makes the big decision to come in and get an HIV test, and then that test is reactive, it can feel terrible to tell that client that they have a preliminary positive result, but they have to have another sample taken and return in a week to find out whether they really have HIV. And this creates a situation where people leave their HIV testing experience confused about their true HIV status. They could be lost to follow-up if they don't return for their confirmatory result, which, as I said before, is an issue that rapid testing is specifically meant to address. And if preliminary positive clients are not immediately linked to care, if organizations wait for confirmatory results before making the linkages, then a valuable opportunity for immediate linkage to care is lost. So an ideal algorithm would help people with HIV to leave their HIV testing experience with certainty about their HIV status and with clear next steps, including linkage to care when it's appropriate. The second challenge that has come up since the advent of rapid testing is that many tests that are considered screening tests are actually now more sensitive than the tests that are FDA approved for use as confirmatory tests, like the Western blot. They've actually advanced far more in technology. So sensitivity is the measure of a test's ability to detect HIV in someone who has it. You want a test to be able to detect HIV as early as possible after someone has been infected, even before they have a ton of antibodies in their system. You want the test to be very sensitive. The ideal screening test is one that misses hardly any true infections. And so this means that they're built to cast a wide net. But a highly sensitive test that catches infection early can sometimes have false positive results. That's sort of the trade-off. And at the screening level, false positives are actually better than missing infections altogether. But it's because of this false positivity rate that confirmatory tests are required. So it's the confirmatory test that separates out which of the positive results are false positives and which are true positives. But there's a real problem when the tests that are approved as confirmatory tests are not as good at detecting HIV infection in people when they've been recently infected and their antibody level is still low. So some of the rapid tests on the market can detect HIV infection earlier than the confirmatory tests such as the Western blot. And what this means is that sometimes a preliminary positive rapid test in a person who really has HIV but was infected very recently could come back with a negative confirmatory test because the confirmatory test just isn't sensitive enough to detect that early infection. So obviously this is a problem, and that's why people who have a preliminary positive followed by a negative confirmatory test have to actually come back for testing again a few weeks later to see whether the Western blot would be positive once they've developed more antibodies, or whether the rapid test was really a false positive. So that's a lot of testing. It produces a lot of anxiety. It's not a fun thing for anybody. With conventional testing, this kind of still exists, but it all happens behind the scenes. So it doesn't impact the clients or the test counselors as much because there's just one final result that comes out almost every time. But with rapid testing, the client is aware of all these processes and questions. It leads to uncertainty about their true HIV status. It leads to doubt about how the tests work, their accuracy, and it often means important missed opportunities for linkage to care for these people, especially if they get fed up with the whole process and just want to go somewhere else, which sometimes does happen. So it's a big issue. The third challenge with the current HIV testing algorithm is that the only FDA-approved confirmatory tests in the U.S. right now test for HIV-1, which is the strain of HIV that is most common in the United States. But it's possible for people in this country to have HIV-2, and sometimes our tests miss them. There's now screening tests that detect HIV-2, and in fact most of the rapid tests that I showed earlier detect HIV-2. But when these preliminary positives are confirmed in the lab, sometimes the confirmatory test results are negative or they're somewhat wonky results because the confirmatory tests don't actually detect HIV-2. So this is a real problem, especially in places where there's more immigrants, more travelers, and higher incidence of HIV-2 infections. And the fourth challenge has to do with acute infection. Acute infection is the period of time right after a person is infected with HIV when their viral load has an initial spike and is very high, but their body hasn't built up any HIV antibodies yet. So it's the first 2 weeks or so of HIV infection. And antibody tests are useless at this time because all the antibody tests on the market, no matter how good they are, will come back negative because the person just doesn't have antibodies yet. Yet this is the time when people are most infectious because they have such a high viral load. So the only way to test for acute infection is to test for the virus itself, not the antibodies. And the problem is that the most common way to do this is with a viral load test, which is really expensive and it takes time to process. It's not realistic for most testing sites to run a viral load on every person who might be acutely infected with HIV. And so some places have tried alternatives to that, including the state of North Carolina and the city of San Francisco, among others. And what they've done is called pooled RNA testing, which I'll talk about briefly. So basically, pooled RNA testing means that a tube of blood is taken from every person who might have acute HIV, and then if they test antibody negative, a small sample of blood is taken from that tube, and it's combined with blood from a bunch of other people who also tested antibody negative. So all those little parts of the specimens are pooled together into one. And then that pooled sample is tested for HIV through a viral load, or otherwise called an RNA test. And if the pool is negative, then you know that all the samples that were added to that pool are negative. You only have to run the test once, and you get the result for everybody who's been in that pool. If the pool is positive, then each individual specimen that went into that pool is then tested individually to determine which one actually has the virus, and then that person who is acutely infected could be contacted immediately and linked to care. So in San Francisco, they do small pools, usually of 10 specimens. They tend to only draw blood on people who have some significant, very recent risk and have a good chance of being acutely infected. So the numbers of samples being pooled are actually smaller than the total population of people being tested. And if they waited for the pool to be bigger, then it would take too long to turn the results around. In North Carolina, though, as a contrast, anybody who tests antibody negative through any public testing site in the whole state has blood sent to an RNA testing pool. So the numbers are large, and they do huge pools, upwards of 200 specimens per pool. And in that case, if the main pool is positive, they actually break it into smaller pools and test the smaller pools first, and then just test individual specimens in any of the small pools that test positive. So there's kind of an extra step in the middle. So while this is a more cost-effective way to detect acute infection, and it's being used in places around the country, like I said, it's logistically challenging. the lack of a systematic way to detect acute infections still means that many, if not most, acute HIV infections in the U.S. go undiagnosed. And since, again, this is a time when people are highly infectious and really unlikely to know that they might be spreading HIV, it's really a critical issue to be addressed. So to address all of these very significant challenges with the old HIV testing algorithm, people have been working for years and years to figure out better ways to use the great technology that we have available today and deal with these issues. And so, as I said, the Clinical and Laboratory Standards Institute has just released new guidelines for HIV testing algorithms. And this is an image of the new algorithm to diagnose HIV in the United States. It looks really complicated, but it's actually pretty straightforward. So I'm going to walk you through it now. Hopefully you can see this little spotlight. So first of all, at the top here is test A1. This is the first antibody test, and that's what the A stands for, is antibody. So antibody test 1. This should be an antibody test that is highly sensitive and uses some of the best technology available today, which is what those terms third or fourth generation mean. So in fact, a fourth generation test actually also looks for HIV antigen, basically presence of the virus, not just antibody. So this helps us to detect people in acute infection right from the start. And any test used for A1 should also detect both HIV-1 and HIV-2. Remember that most rapid tests on the market already do this. And right now there's only one test on the market in the U.S. that's a fourth generation rapid HIV test, and it's not a CLIA waived test. So that's why the algorithm says you can use third generation tests even though they only detect antibodies. So ideally you would use that fourth generation one, but third is the best substitute if you're a CLIA waived site. So with this new algorithm, if the A1 test is negative over here, then we say that the person is HIV negative. We talk about the window period, especially if it's not a fourth generation test that's looking for the virus, and we recommend that they test again at some reasonable interval in the future. It's basically just like HIV testing that happens now. But if test A1 is positive, then you go to this side of the chart, and the new algorithm says that we actually perform a second HIV test, which is labeled here as A2. So this test needs to be able to differentiate between HIV-1 and HIV-2, which is information that's important for a clinician to know when someone is linked to care. So the test can tell the difference. And if the test 2 is HIV-1 positive, then the person is told that they have HIV-1 and they're linked to care. And they should get a viral load test at that time. If the person is HIV-2, if the test A2 is HIV-2 positive, then the person is told that they have HIV-2 and linked to care. And with that information that it's HIV-2, that's really important that the clinician knows that there are different types of tests they should be running and different things that they should be looking for than the typical way that we normally handle HIV in the US when it's HIV-1. So if the test A2 is negative for both HIV-1 and HIV-2 antibodies, as is over here, then the sample would be tested for RNA, which is the presence of the virus. And this is because even though A2 detected no antibodies, A1 did detect antibodies. So it's possible that the person is acutely infected. We just don't know exactly what's happening. So if the RNA test comes back positive, right here, then the person is told that they have acute HIV infection and they're linked to care right away. If the RNA test comes back negative, then it's assumed that A1 was actually a false positive result, that A2 coming back negative was accurate, and that the person is HIV negative, but they're encouraged to test again at some reasonable interval in the future. In this case, the window period isn't such a big deal unless it's something that happened in the last, say, week or so, because we've actually looked for presence of the virus, which is detected pretty early. But it's still something to talk about. I mean, with any test, there's some kind of window period. If somebody was infected 2 days ago, then even an RNA test would likely still be negative. So that's the summary. This new algorithm, as you can see, is a really big change. The Western blot confirmatory test in this case is essentially gone. And the new algorithm addresses all the challenges of the old algorithm that I just went through. So it's a huge change in the US. So remember that everything in this section is based on the new CLSI recommendations, and it's not been finalized in any new CDC or state level policies, which is likely to take some time. But we share this information because we wanted to give you a sneak preview of what's up and coming since it's such a big change, and to prepare you for these potential big changes ahead so that you can, as you're setting up programs or thinking about future directions for your HIV testing programs, you can be aware of these things. And with these changes, we'll really be able to provide better, more accurate information more quickly to our clients. So this is a really excellent move forward in the United States. That's the overview. So now I'm going to hand it off to Sonia for some closing thoughts. And then I'm sure that, I know we're just about at the time limit, so there's some quick closing thoughts, and then I think we'll have time to be able to stay for more Q&A for those of you who can stay over.
Thank you so much, Shelley. Just before I close this out, I want to just say thank you to everybody for all your participation in the chatting in the best practices and challenges that you're seeing in your organizations. We have gotten a lot of questions. We will do our best to stay online and continue answering your questions, but we apologize for not getting to all of them. And please feel free to follow up with us individually after this webinar. I think really we just want to close out by saying that it's a really exciting and a bit tumultuous time in the HIV testing world. There's lots of new things coming on the market in terms of new testing technologies. This new algorithm is potentially going to really change how we do HIV testing, and that it's a really great time to be networking and collaborating. So out of the folks on today's webinar, there's been a huge amount of expertise, and one of the best practices, actually a few of the best practices we shared, is really about making sure to formalize those relationships and learn from each other's best practices and experiences. So I want to just encourage folks to stay in contact and stay networked. I want to talk a little bit about some of the further resources available through us. So today's webinar was recorded. It is part of a 3-part series on high impact HIV prevention. That obviously is a big set of changes that is happening right now in terms of how we do prevention programming overall, not just how we do our testing programming. And all of the 3 parts of that webinar series were recorded, and they all also have online modules, online training modules available, and that's all on our website. You'll see the website link at the bottom of this page. And specifically for today's webinar, there are some information sheets that sort of summarize and capture the content we talked about. There's a couple of kind of basic overview sheets on CTR, on HIV testing, on rapid testing, some of the best practices, and then there's a high impact HIV testing sheet which talks a bit about the effective models, PCC and RESPECT in particular. There's a lot more information about PCC and RESPECT on the CDC's High Impact HIV Prevention website, which is effectiveinterventions.org. There's sort of overview materials as well as some of the implementation manuals, and the CDC offers free training on both PCC and RESPECT, and links to the training calendar are on that website. So in terms of our online resource library, if we can actually go forward one more slide, Shelley, we have these recorded webinars, we have the information sheets, we have online training modules for all 3 of the parts of this high impact HIV prevention series, and the website, the http://library.capacityforhealth.org is on your screen. We'll also send out a link with the follow-up for today's webinar to those materials, and please feel free to contact us. You know, as I said, we do provide individual capacity building, so we can work directly with you and your organization around how to implement some of these best practices in HIV testing, or how to make some adjustments in terms of the HIV testing services you're already providing. So the phone number and email you see on your screen are how you can follow up with us if you'd like some individual capacity building assistance. We're going to go ahead and stay on the line and try to answer any further questions that you have. You can feel free to click on your raise the hand icon and we can call on you. You can ask your question live, or if you prefer, you can chat it in the questions window, and we will try to address those. Thank you, everybody who needs to sign off. Thank you for joining us today. It's been really, really exciting to see this huge turnout. I think people are very excited about high-impact HIV prevention in general, and we've gotten a great response to this series. So thank you for your attendance and your participation. Shelley, we've gotten a few questions about NAT testing for acute infection. I know we're not going to be able to cover all of the different kind of testing technologies right now, but do you want to add anything about NAT testing?
I'm not sure exactly what the questions are, but I will say NAT testing, so that's nucleic acid amplification testing is what that stands for, and that's essentially what I was talking about when I said RNA testing. So viral load testing, RNA testing, NAT testing, while technically they all mean slightly different things, they're essentially, people often use those words interchangeably. So the sections about pooled RNA testing and using RNA testing in that bottom right of the algorithm as after, if A1 is positive and A2 is negative, you do RNA testing. That's really what we're talking about there is NAT testing. So I'm not sure if that clears up the questions or not, but that's a brief thing. I should have used that term to make sure people knew that was the right thing.
Shelley, do you want to go ahead and put that new testing algorithm slide back up?
Sure.
We have a few other questions about it. So one of the questions is about the difference at the A2 stage. Somebody asks, what's the difference between this test and the current Western blot in the A2 stage?
Well, essentially, so in the in the A2 stage, so we're talking about right here. So the Western blot, first of all, is really made to look for HIV-1 specifically. So it certainly doesn't differentiate between HIV-1 and HIV-2. Although people who are really skilled in reading the Western blot can often kind of predict by the pattern of bands what's going on. The way a Western blot looks, you see a bunch of specific bands related to HIV. And so based on what they're seeing those results visually look like, they can often kind of figure out, like, maybe this person has HIV too, maybe this is going on, maybe they're in the process of seroconverting but they were very recently infected, all those kinds of things. Someone who really has a lot of skill with it can often tell those things, but the test really isn't intended for any of those purposes. It's really intended, there's very strict, in the current algorithm it basically says the Western blot needs to look like X, and then you can say this person has HIV. And it's really, whatever X is meant to be when that person is fully antibody positive for HIV-1. And so for years, there have been all these nuances with it, and people have tried to figure out how to negotiate that. But the idea behind the algorithm is to use a test for A2 that just provides a very clean result. There's no nuance that has to be interpreted by someone who has a lot of expertise with that particular test. It's a lot easier to just say it's HIV-1 positive or it's HIV-2 positive. It distinguishes between the two, and it's a very clear result. So that's the idea.
Thank you, Shelley. I'm going to keep giving you questions about this particular slide, and then I'll move on to some other questions. Somebody asked if you could just clarify again what's happening in that right-hand part that says A1 negative, and whether or not that's being tested for virus.
Okay, so if test A1 is a fourth-generation test, which means that it looks for antibodies and P24 antigen. Now, P24 antigen is basically a piece of the HIV virus itself, and so by saying that it tests for P24 antigen, you're basically saying it tests for the presence of the virus and not just for antibodies. So a fourth-generation test will look for both of those, which means that if you use a fourth-generation test for A1 and it's negative, then you know that person does not have HIV or HIV-1 or HIV-2 antibodies or any antigen. So basically, it's a pretty clean negative result. But as I said, right now, there's only one fourth-generation rapid test out there, and it's not CLIA waived. So it's not available to a lot of the testing sites that would like to use this kind of algorithm. So those sites, for now, have to basically settle for the best third-generation tests out there, which are not testing for antigen. So in that case, if this condition here occurs in A1 being negative, you're able to say you're negative for HIV-1 and HIV-2 antibodies on this highly sensitive test we used, but we weren't testing for the presence of the virus, so we want to talk to you about how the window period works, and that depending on when you were infected, it's a good idea, when you could have been infected from risk, it's a good idea to test again in the future to rule out that kind of infection. So the same kind of language around window period that we've been using, you would still have to use in this case.
Thank you so much, Shelley. We've definitely gotten a few other specific questions about the algorithm on this slide. I'm going to try to respond to some of those in writing and also just encourage folks to follow up with us individually. We got another question about creating social marketing strategies, and I think it's more of a comment than a question, but the question is how we can all come together, create a social marketing strategy all across the country at the same time to respond aggressively. So I'm going to just throw that back out to everyone who's still on the webinar and say, please chat in your advice about social marketing strategies. I think that that's a good point about the importance of social marketing, and in the CDC's new High Impact HIV Prevention approach, they actually include social marketing as one of the types of interventions that they're considering to be high impact. And there are some great resources on the effectiveinterventions.org website, including a social marketing toolkit about developing and implementing social marketing campaigns. So I will refer you to effectiveinterventions.org as well as to whatever comments people can chat in about their social marketing campaigns. I'm going to go ahead and close us out, I think, at this stage, unless somebody would like to ask questions live. We've gotten a bunch of questions about the algorithm, which I think you've mostly covered. Somebody did ask Shelley about the approved third and fourth generation tests and what they are at this point. We can refer folks to follow up with us more specifically if you'd like.
Yeah, I mean, I think that's what I'm trying to think of the easiest way to actually provide that information. And I think the best thing to do would be to follow up directly with Sonia, with Capacity for Health, and I will make sure that if they don't already have it, that they have the updated information about what's approved. Part of the challenge is that it's just changing so much. This is a field that people are really all over and wanting to improve so quickly that you know, it's changing quickly, and I'll make sure that they have the updated info, and then you can get that directly.
Thank you so much, Shelley. So we're going to go ahead and close out. If you don't mind, Shelley, just putting our contact information, that last slide, back up on the screen for a minute. I'm so grateful that there are so many people who have been so excited about this topic and have so many great questions. So please don't hesitate to get in touch with us at the phone number and email address on your screen. We'd be happy to continue answering more questions about high-impact HIV testing as well as high-impact HIV prevention in general. And we are more than happy to work with you individually around some of your organizational needs in terms of implementing more effective HIV testing programs. So just by way of closing, I want to thank our lovely guest speaker, Shelley Facente, again for joining us for today's webinar as well as for this whole series on high-impact HIV prevention. It's been a delight to have you with us over the last few months working on this series, and we really appreciate all of your time and commitment as well as all the time of all of you who've been participating in today's webinar. So thank you so much for your attendance and your participation. Please follow up with us and access some of these further resources, and we look forward to seeing you on future webinars.